de incluir en este evento la interpretación del lenguaje de señas mexicana, lo cual permite que este foro llegue a más personas. Los intérpretes de esta sesión son la maestra en lenguas modernas, Dayana Vianey Razo Rosales, el licenciado en traducción Lucas Nash Everett Muñiz, y como les mencionamos, se contará con un canal de YouTube con interpretación en inglés, que es YouTube Divulgares Escuela UABC. También tenemos un canal en español, que es el canal de YouTube de Remi TV. También tenemos la transmisión en Facebook de Remi TV. Y también tenemos la transmisión en Imagen TV de UABC. Este foro está realizado gracias al apoyo de diferentes instituciones, de la Escuela de Ciencias de la Salud a través del programa de internacionalización en casa de la Universidad Autónoma de Baja California, gracias a la Comisión de Salud Fronteriza México-Estados Unidos, a la Red Temática Binacional de Salud Fronteriza, a la Red Multidisciplinaria de Investigación en Tuberculosis, al Centro Nacional de Programas Preventivos y Control de Enfermedades de la Secretaría de Salud de Gobernación de México, y la Red Nacional de Investigación para la Prevención y Control de Tuberculosis en México. Asimismo, deseamos mencionar que este foro tiene lugar en el marco del Mes de la Salud Fronteriza México-Estados Unidos. Es importante resaltar que el objetivo del foro es generar un canal de acceso a la innovación científica y la colaboración biomédica a nivel internacional con respecto a la prevención, diagnóstico y tratamiento de la tuberculosis bajo el nuevo escenario del COVID-19 y de esta manera estar preparados para posibles o nuevas pandemias. El día de hoy tenemos la participación de dos excelentes investigadores. Comenzaremos con la presentación de la doctora Mikashmi Kohli, que tiene preparado para nosotros. La doctora Mikashmi está en Ginebra, Suiza, y pertenece al departamento de Suiza, ¿no? Entonces, doctora Mikashmi, tiene usted 40 minutos para la presentación, de los cuales al finalizar vamos a tener 10 minutos para preguntas y respuestas. Usted va a poder ver aquí en un panel el cronómetro de sus 40 minutos. Entonces, si es tan amable, doctora, de empezar, por favor. Les recordamos a los asistentes que para tener constancia de participación tienen que hacer su registro al menos a 6 sesiones. En la pantalla va a aparecer un código QR al principio y de forma intermitente para que ustedes puedan generar su registro. Gracias.
Okay, Luisa, do I go ahead with it?
Yes, please.
Perfect. Okay, hello everyone. As Luisa mentioned in Spanish, and I could not understand most of it, but my name is Mikashmi, and I will be talking about Xpert MTB-RIF and Ultra for diagnosing extrapulmonary TB, that is evidence to policy. So there are going to be a lot of parts to this presentation, but we are going to start backwards and see what do we mean when we say evidence. So evidence is basically available body of facts or information that indicates whether a belief or proposition is true or is it valid or not. Historically, medical training and common sense usually were used and they were considered sufficient for evaluating whether it should be new test or new treatment. The first randomized control trial, which is now the reference standard for any new test or new drug, was published in 1948. So now with the growing newer technologies and newer drugs coming up, it is important to understand what is it that we are putting out there, how do we make decisions, how do clinicians make decisions based on this newer information that is coming out. And this is done using evidence-based medicine. What is this evidence? How do we synthesize it? And then how do we use it is an important factor. And we're going to talk a little bit about it. So in the hierarchy of scientific evidence, usually there are case reports or opinion papers. And then there are animal trials and lab studies that are done. There are cross-sectional studies, case control, cohort studies, randomized control trials that I mentioned. And then there are systematic reviews and meta-analysis. So this is how it goes in the spectrum of hierarchy for scientific evidence. Some of this based on whether it's personal anecdotes or it's YouTube videos or just something in the newspaper that somebody stated is not considered as scientific evidence. So the kind of work that all of you do in the lab, it escalates to creating evidence and how that is done. So one part of it is doing a systematic review, and what it means is that you clearly formulate a research question. What is it that you want to answer? And then you try and find out what is the proper protocol. There are explicit methods to identify, select, and critically appraise the publications that are already out there. And then you collect all that data, analyze it, and then include it in your review. So this is sort of like a figure that we use a lot to say what systematic review and meta-analysis are. So it's like the outer phase is all the reviews or all the published studies, and then the yolk of the egg is the systematic review, and a part of that is put together, synthesized, analyzed, which is the meta-analysis. So in essence, systematic reviews summarize the findings so people make important decisions. How does your doctor tell you that this is the drug that you should be using, or this is the test that you should be getting tested with? These are the kind of information that is put together, and then it is used in creating decisions or making decisions by your clinicians or your policymakers. But why do we do that? Why do we need to do a review? Why do we need to create evidence or synthesize it? One part, and the very recent example, is COVID. I think all of us know in the last 2 years, there were so many publications on COVID. Every single day, there were tens and hundreds of publications every month, maybe. And this was one of the papers that was published in the Nature, stating how the number of publications that increased in 1 year just on COVID. So that's precisely the point. You keep reading. You cannot keep reading each and every paper every single day. So what do we do? And how to make sense of it? Same is the case with TB. We can see that over the last 1 decade, there have been an increase in the number of TB studies. There has been an increase in the number of systematic reviews that happen. So these are the kind of publications that go out and they're exploding. So we don't want to end up in this situation where we have to keep reading each of these papers. So that's why we do a systematic review where we are trying to make sense of all of this publication that is out there so that a decision, an evidence-based decision, can be made. So what are systematic reviews? They summarize all the available evidence, and they are transparent and reproducible because they give a clear indication of what the research question is, how are you going to synthesize the evidence, how are you going to evaluate it. All that methodology is written, so that's why it's transparent. It improves the healthcare decision making and equity. It allows studies to be formally compared. So the reason that I say this is because there are many studies out there. Some may be done in the US, some may be done in Mexico, for example, or Uganda, India. How do you make sense of it? What do we do with it? So that's why we create or we do a systematic review so that we can formally compare these studies. And they provide vehicle for translating research into policies. And I'll be telling you how that policy is made and what really happens in that process. And they provide vehicle for these reviews provide credible information to support informed decision making, important for improving global health. So these are the 10 steps broadly that go into doing the review. It's like you formulate the question, you define your objective and the eligibility criteria that goes into it, and you write a proper protocol. So this is where you involve a team because this is something that cannot be done by one single person. So you need to have methodologists, you need to have people who have worked in the lab, clinicians, statisticians. So you need to have a good team in order to do that. Then you search the literature for all the published data. You screen the abstracts, you extract the data. An important part of it is assessing the quality of the studies that are included. And then you perform statistical analysis, interpret the results, and then update the review if needed. But each of these steps take a really long time. So even if it's saying that it's just 10 steps, sometimes a systematic review can take for example, 2 years to do a good systematic review. So this is just an animated slide, and I'm just going to run through it, is to tell you what really happens. So you do a systematic review, and there is a guideline development panel somewhere sitting at WHO. So they will basically tell you that this is the question that is important for public health point of view. So they give us that PICO question, which they formulate. They give us the outcomes that are important, for example, to test for public health. Is this diagnostic test good enough? Should we be putting it out there to be tested on, to be used on people or not? Similarly for drugs, is that drug good enough to be used or not in populations? And these are the kind of questions that, when given from the guideline development panel to the PICO question, the review team, the systematic review team that I said we need to put together, then tries to answer that question. And how do you do that is you go through all the literature, you define your objectives, you define the outcomes, and then you create that evidence using statistical analysis, but you also try and assess what is the quality of the study. You rate the evidence based on high, moderate, low, very low, based on one, the statistical analysis, two, the quality of the study, and third, how well these outcomes were reported in these studies that you actually wanted to answer. So you either grade up or grade down, and then all of this data is put together and then goes to the guideline development group who actually gave you the question to be answered. And then they review and make recommendations whether you should be using that test or not, whether you should be using that drug or not. And then apart from the statistical analysis, there are other parts that goes into it. For example, what are the benefits? What are the harms? What are the values? Will the patient be willing to accept it? Will the provider be willing to accept it? So all these things go into making a policy. And now getting to the meat of it, this is one of the systematic reviews that I was the first author on, and this was my first systematic review. So the question here was whether Xpert MTB-RIF and Ultra should be used for detecting extrapulmonary tuberculosis in adults or not. So we did this whole process of creating evidence and analyzing it, and then we published it in the Cochrane Library. This was the team that I had, and it was a great team that we put together for this systematic review. So we know that about 10 million cases of TB occur every year, and 15% of those cases are extrapulmonary TB, which is even difficult to diagnose because it is postbacillary in nature. Most of the tests cannot detect because the bacillary load is very low. So Xpert MTB-RIF was one of the first molecular tests that came up with a very good and optimal diagnostic test accuracy that we wanted to use, and it was used and recommended in pulmonary TB, where we take the sputum of the patient and then try and diagnose TB. But with extrapulmonary TB, which can occur in any part of the body, we did not know what the evidence is. Should doctors even be using it or not? So we performed a review and updated it also recently to understand Xpert and the newer version of the test. So Xpert MTB-RIF came in 2010, but then a newer version and a better version of this test came very recently, which was then named the Xpert Ultra. That test was said that it can diagnose, it has a lower limit of detection, so can diagnose TB even better. So our PICO question, as I said, was among adults with signs and symptoms of extrapulmonary TB who are seeking care at healthcare facilities, should Xpert MTB-RIF or Xpert Ultra be used as initial test for diagnosis of extrapulmonary TB and also rifampicin resistance? So we know that's the first line of drug that people are given for treating TB. Should we be using that or not? Or what if can we diagnose using this test if they are resistant for rifampicin or not? This is what the test does, detecting TB and rifampicin resistance simultaneously. So one part of the review is that you read a lot of papers. So as part of this review, we had 999 papers that were reviewed and read, and we came up to, and then we screen through all of these. We read the abstract. Some of them are not relevant. Some of them are relevant to our question. So that is why we do an abstract screening and then we do a full text screening. So after going through all those steps, we came up to a total of 69 studies, out of which 67 reviewed Xpert MTB-RIF and 11 reviewed Ultra. So some of them actually did both. So that is why the total is 69, because some of the studies had both Xpert and Xpert MTB-RIF, Ultra and Xpert MTB-RIF. As I said, there were 67 studies with Xpert MTB-RIF, 11 had also reviewed Ultra. Out of these, 60% actually took place in high TB burden countries and 61% took place in high HIV TB burden countries as per the WHO list. So what we did was that we stratified the data based on specimen type. As we know, the TB can basically occur in lymph nodes or in the brain with cerebrospinal fluid, or in the lungs with pleural fluid, or in the heart with pericardial fluid effusion. So we stratified the analysis based on different specimen type. Also did stratified analysis based on Xpert MTB-RIF and Ultra. And then we had a microbiological reference standard, which basically included TB culture. And then we had a composite reference standard where even if the culture is negative or not optimal, sometimes doctors decide based on other tests or clinical decisions that we are going to put the patient on treatment, which was consisted of the composite reference standard. So this is just a table showing the different kinds of specimen types that we had. We had cerebrospinal fluid, lymph node fluid, but also tissue, pleural fluid. We assessed urine, bone or joint fluid, we assessed peritoneal fluid, pericardial, and blood. So these tick marks are basically saying that on what parameters we had data. So for MRS basically is microbiological, CRS is a composite reference standard. So for all of these, we had data based from our review, and we tried and put all of that together to provide evidence. I'm not going to go through all of them, but they're definitely available. If any particular extrapulmonary TB type is of interest, you can go read the review. But also I'm going to go through a couple of those which were important for policy making. So TB meningitis, we all know, is a very serious condition. People need to be diagnosed rapidly and accurately. Otherwise, the case fatality rate is really high. So our question was, should expert MTB-RIF be used to diagnose TB meningitis in cerebrospinal fluid against microbiological reference standard? So when I said that there were all of these different studies, we actually read all of these different studies, we extracted the data from all of them, and this is what is called a forest plot. So we looked at the forest plots, we looked at we put together the sensitivity specificity of this test, and then we meta-analyzed it. So in total, we had 30 studies, 3,395 participants. And when we pooled all of this data together, the sensitivity was 71.1% and the specificity was 96.9%. So for something like cerebrospinal fluid, we actually felt that this test is doing good and it is very optimal because if you can detect with such high specificity whether the patient has TB meningitis or not, you will be able to put that patient on treatment, and the test result comes in 2 hours, so which is even better. The patient is not going to fall out of the cascade. They can be put on treatment faster, and the treatment outcomes can be better. And then, as I said, that we need to have the quality of the study also to be assessed. So there are different domains in how we assess the quality of the study: the patient selection, the index test, how it was done, the reference standard, and the flow and timing. So this is how the study quality looked like using the Quadus 2 tool for diagnostic test accuracy. And we looked at all of these 30 studies to begin with. Then we did the same thing with the newer version of the test, which was Xpert Ultra, to diagnose TB meningitis. We had fewer studies because, as I said, this was a newer test, an upgraded version. So this is how the studies look like, the forest plot, and the quality of the studies look like, so not bad. And we had 6 studies with 475 participants. Again, because as I said that this newer test had a lower limit of detection, so the sensitivity increased from 71% to 89%, and the specificity was 91.2%. Again, pretty optimal for diagnosing TB meningitis. Then we looked at the same for lymph node TB, and there are 2 different specimen types for lymph node TB. One is lymph node TB fluid, and the other is tissue. So when we looked at the fluid against a microbiological reference standard, we had a total of 14 studies, over 1,500 participants, and the pooled sensitivity was 88.7% and the specificity was 86%. So there was a lower specificity for lymph node aspirate because, and we tried evaluating what is going on with the specificity. So this issue was that, as you know, that the TB in the lymph node, it's very difficult to get that specimen. Sometimes the bacilli forms cavities, so it is difficult to get a viable bacteria or even any bacillary load. So sometimes it gives false positives and lower specificity, but also sometimes Xpert may be positive, but the culture is negative, because in most of these studies, what they were doing was that they were taking the aspirate and they were decontaminating using NALC NaOH method and then trying to grow on culture. But that was leading to shutting down or decreasing the viable bacteria in the specimen. So the culture positivity rate was even lower. That is why possibly we had lower specificity with Xpert on this test, on the specimen, sorry. We tried evaluating it using a composite reference standard where even though culture may be negative, but still the doctor says, okay, other tests are positive. So we looked at that as well. There were 4 studies, and as expected, the sensitivity was 81%, but as expected, the specificity increased because sometimes the culture may be completely negative, as I explained why it could be negative, but still empirically or based on other standard of care tests, the doctor may say, okay, you still have TB. And that is where the test really performed good. And we knew that it is possible to detect lymph node TB with good certainty using Xpert MTB-RIF. Then we looked at the lymph node tissue, the biopsy specimen that we get. And this is how its forest plot looked like. So we had 11 studies, about more than 700 specimens that provided this data. And again, looking at the microbiological reference standard, we had a pool sensitivity of 82%, but a very low specificity of 79.3%. So again, the specificity issues, as I stated with lymph node aspirates, they were the same with lymph node tissue as well, because the culture were negative in most of these specimens. And then we looked at pleural TB, which again is very difficult to diagnose using the pleural tapping that happens, the fluid that develops around the lung. So we tried evaluating how it may look like with Xpert. And we looked at the microbiological and the composite, but here I'm going to show how the composite reference standard looked like. We had 10 studies, about 1,000 specimens. The sensitivity was very low. It was 19%, but the specificity was very high. So what it means is that if using Xpert, your test is saying that it's positive, it is very less likely that it's going to be a false positive. So if it says positive, you can actually say that, yes, the patient has pleural TB, and you will put them on treatment for further treatment outcomes. So that is why a higher specificity is appreciated for a diagnostic test. Then, as I said, that there were all these different types of TB forms, meningitis, pleural, pericardial, and there is a whole long list that is published in our review. But also this test gives the status of rifampicin resistance, which is great. If in 2 hours you can get that, that is amazing. So we looked at how this test is performing with respect to rifampicin resistance. So when we meta-analyzed this data, there were 23 studies, about 1,000 specimens, and the sensitivity and specificity were optimal with 96% sensitivity and 98.8, so 99% specificity. So again, if the test says that it is rifampicin resistant, you will not put the patient on rifampicin drug regimen. So this is just a snapshot of saying the different specimen types that I said we assessed with different index tests and different reference standards. So all these estimates are out there. If any specific form of TB is of interest, you can go and look at this publication. We did all the overall analysis, but also stratified and subgroup analysis have been put there in the publication. So in summary, the performance of this test ranges from 50% to 97%, and the specificity is actually high in all different specimen types. So it is a good rule-in test, diagnostic test. Xpert MTB-RIF and the newer version of the test, the Ultra, has very similar sensitivity and specificity for rifampicin resistance as we saw. So again, with 23 studies for MTB-RIF, 96% sensitivity, 99% specificity. With Ultra, there were 5 studies, but still very similar sensitivity and specificity. I would just like to thank the great author team that I had the opportunity to work with, and all the primary authors, because as part of this review, we went back to many of these authors and asked them for their primary data, and they were very kind enough to provide us with that. So this was one of the case studies, but as I said, we did all of this work, and how it really formulated is that the World Health Organization asked us to perform this. We looked at all of this evidence. We provided this evidence to the guideline development group at WHO. And these are the different policy updates that were published by WHO. And now recently they have come up with this guideline book on diagnosis, which is module 3. And you will also find most of this work being published in this consolidated guidelines. And thank you so much. I would be happy to take any questions on the presentation. Yeah, thank you.
Dr. Mikashmi, thanks for your presentation. I want to remind you that in the Zoom, we have an icon below that says interpretation. It's a word. You can press the icon and select for traduction for the next part.
Okay.
Okay.
Thank you.
Questions, preguntas, Luisa, te las paso aquí en el chat.
Gracias.
Luisa and Raquel, I'll try to be on the call, but I do have another call that I need to attend. But if there are any questions from the audience at any point, I would be happy to also answer them via email or anything, if not now.
Okay, we have just one question. You can answer right now?
For sure, yes.
Okay. What do you think about the sequencing of the new generation in the use of the Xpert?
So you mean how can we use it, or are we using it or not? Sorry, I didn't get the question. Sorry.
The use, have you been using?
Yes. So yes, I think that's a great question. Now with Xpert MTB RIF, even though we just get to know about TB and rifampicin, the next generation sequencing, absolutely, it's being upscaled, and we are using it in many different countries and setting up next generation sequencing, the whole genome, and also targeted sequencing to know drug resistance or drug susceptibility profiling. So that is something that is definitely happening. But there is one caveat to that, that the technology is very high scale. So it is very difficult to decentralize or to put it as point of care, whereas Xpert right now is almost as used as point of care. It can give you rapid test. So but hopefully in the near future, we should be able to use and get next generation sequencing to the patient. Hopefully the technology improves, but definitely that is being used and being upscaled all across the globe and in different parts of the world, yes.
Okay, thank you. I think there is no more questions in the chat, but can you tell us your email for further question?
Yes, Raquel already has it. I'll put it in the chat. But if there are any questions, I would be happy to take them.
Thank you very much, Doctor. Ok, pues muchas gracias a la participación de la doctora.
Thank you so much to our kind presenter. We're going to give a 5-minute recess so that we can start again with our new speaker, or with our next speaker rather. So we're on a 5-minute recess. Thank you.
Jesús Sánchez.
Our next speaker is Dr. María de Jesús Sánchez. She is part of the CDC. She represents the Pan American Health Organization in Mexico, and she's specialized on the TB epidemiology overview. She is a biologist from the UK York University, and she has over 15 years of experience in epidemiology in the field of public health, in the areas of development and design of prevention and control of transmissible diseases, and she is the coordinator of the health determiners, and that's where she supports all of the health programs such as HIV programs, hepatitis, microbacteriosis, born transmitted diseases, as well as other diseases. So we welcome.
Hola, muy buenos días a todos. Muchísimas gracias por tu presentación. Yo quería saber si
everyone, thank you so much for your presentation. I want to know if you received my presentation last night, and if you're going to be able to share it on your screen.
Todavía no se ve, Luis.
Okay.
Ahora sí.
Okay, now we can see it. I don't know if you can all see it all right now.
Nada más va a dar Luisa un aviso.
Okay. Okay, Luisa is just going to give some information as far as your, in order to get a diploma from being a part of this forum, you have to register on the QR, through the QR code. You need to be present in 6 of the sessions in order to get a certificate. I also remind you that you have 40 minutes for your presentation, and at the end, we're going to allocate 10 minutes for Q&A. Okay, so if you were able to keep me, if you were so kind as to keep me on time and letting me know how I'm doing. Thank you so much for the invitation to be a part of this forum. It is super important to me to have the opportunity to be sharing about this opportunity that you have given me to update you. And I would like to let you know that all of the data that I have for to share with you were given by me through the regional TB program through the OPS in Mexico, and they're based fundamentally on the TB World Report. And I apologize because some of the slides have not been updated because not all of the information at a regional level has been released from on behalf of the WHO or the OPS, which is the Pan American Health Organization. Next slide, please. Well, beginning with the global burden of tuberculosis, it is important to mention that last year there were almost 10 new cases reported globally. Now, and this has been published. 1.28 million deaths due to TB have been registered within people without HIV. So when we analyze the number of people that were dying from COVID, made us think that TB had a load that was very similar to the one that COVID had. And this made us reflect on this global disease, which is not a pandemic, but it has a very important load. 214,000 deaths are calculated among HIV people. And there are about 465,000 new cases of TB-RR, and 78% of them are TB-MDR. Now, the global report is not done by the OPS. Each one of the countries have their own codes, and they are then reviewed by the OPS team in Geneva. And after having been verified, they are published in one platform which reports all of these data. Next slide, please. What is the most important thing that we got from this global report? Well, we've seen a global trend in case notifications of people newly diagnosed with TB. This is including all of the data that is reported to this report. Obviously, the impact that the COVID pandemic has had is being reflected on the activities through the prevention and control programs for tuberculosis. We're going to talk about more details about this. In many cases, a lot of the things that were taking place have to be canceled due to the pandemic, also because a lot of people did not want to go to the health centers to be tested for tuberculosis. So this has reflected on a drastic descent of case notification. Next slide, please. Well, this notification of all new cases, which we can see in a group graph for all of the world, overall the countries that report, is the generalized trend. These are the trends in case notifications of people newly diagnosed with TB by the WHO region in 2016 and 2020. Most of the cases are reported in Brazil and Peru, and all of the regions have been truly impacted by COVID. Some of them in Europe had already been showing less notified cases. But truly, next slide, but truly, the Europe region wouldn't have had this trend if it had not been due to the pandemic. Now, the pandemic has affected all of these in an important way. We can also see how the COVID pandemic has impacted negatively as far as the number of deaths, which is represented on the left graph in black, and we can also see the number of people that live with HIV and TB, and globally 1.3 million of HIV negative people have been registered as deaths due to tuberculosis. And this is the first increase that we have seen since the year 2005, which means that we have been observing an important impact. So according to all of this data, what we had been able to advance from 2017 to 2019 has been driven in reverse since the COVID-19 pandemic. Now for 2019, and after the COVID pandemic, tuberculosis is going to be the second most important cause of death due to an infectious agent. So this is a public health issue. The next slide, which I also want you to see as far as the global report, which shows the rate per 100,000 population per year. We have not seen the same impact in the number of deaths, for example, as far as the incidence rates, even though there are over 9 million people who got sick during 2020. There's a rate of 7 cases per 100,000 population per year, and we have not seen an increased peak. And this is because of different reasons that could be explored. But really, one of the explanations that is being given from the WHO is that the services given which have been so impacted by the pandemic does not have such a quick impact such as the deaths. And people that are being diagnosed and that are under treatment, once these services were stopped, this has impacted the number of deaths. And this is something that we might continue seeing for a little longer. Now, these are the trends, and we have not seen important increases, especially in Latin America, where we have been seeing an increase since the year 2016, which I'm going to talk about a little bit more in detail later. This is the map with the different countries with the incidence rate at a global rate. The countries with darker colors are the ones with an higher incidence rate. In the Americas, we have 2 that are higher in as far as this rate. are Peru and Brazil. At a global level, the Americas is not the region that presents the higher estimate rate. We have Africa and the Southeast or the West Pacific, which really represents the highest load rate, and we only represent a very small percentage of disease load at an international level. But we have to keep trying to advance to the goals that we have set for ourselves. Now, on the next slide, I would just like to mention some of the commitments that we have as a region at a global level in order to continue fighting tuberculosis. We're not lacking commitment or strategies, and we're not lacking indicators or global goals. I would just like some of them. Since 2014, there has been an intense activity so that we can put tuberculosis as a health, as an important international health issue. And during 2018, we got a global assembly about this, but then COVID hit and the situation completely changed. But truly, from all of these commitments and goals and strategies, how are we doing at a global level? So first, the TB incidence rate, and this is the information from the WHO and TB strategy. These are the milestones for 2020, and we're not doing great because we're not close to the goals that we had established for the year 2020. As far as the incidence rate, we're far from the 20% goal that we had established for the year 2020. We are at 20%. And the number of TB deaths is the same story. The next one, as far as the indicators of the UN high-level meeting on TB treatment targets, we have not been able to advance, and we're far from the goals that we had established for the year 2020. Now, the only one that we can highlight in a positive way is that we have met treatment for people that are living with HIV. So at least we have advanced on this issue, but we're very, very far from meeting the goals that we have established for the year 2022. Now, the next slide, please. So a little bit more detail about tuberculosis situation in the Americas. The same information, but just for our region, 290,000 cases for the year 2020, 26,900 deaths. This is a disease that affects men a little bit more than women, and the incidence is in people over 15 years of age. And all of these tells us that even though we're not a region with a really great load, we hope that we can comply with the goals that we have established through the different strategies that we have also established in order to do so. So how far are we from these goals? Well, as you can see, the estimate deaths, this graph indicates us that the projection that we had according to the dotted blue line, this shows what we have been doing from the control programs, and we were very far from the goals that we had established, and we would need to start going towards the green line in order to start following the curve that we should be following as far as decreasing the number of estimated deaths. But 2020 set us even further back, because we can see that since 2015, we have seen an increase from 6 to about 9%. So we're completely out of the goals that we had established for the sustainable development objectives. The next slide shows us how we've been advancing in the Americas as far as the estimate incidence, and it's about the same view. We were on the dotted blue line, and now that would have to make a big turnaround so that we can start going through the path that will take us to the established goals for 2030 or 2035. But COVID, and even before COVID, the American region was already showing an increase on these rates since approximately 2016. So we're far from the curve that will allow us to advance on this matter. Next slide, please. As far as the estimate cases as well as the notified TB cases for the region, the red line indicates the estimates, with the shaded area will be the uncertain cases, and the blue line shows us the notified cases, and we can see that the gap has not, and it's not close to being closed, and the gap opened significantly, so it set us back as far as new case notifications. So this gap opened importantly, and this is the direct impact of the pandemic on the health services. Next slide, please. Another slide where I want to show you that, and these are not a part of the global report because they're handled from each region, and these are the countries with higher loads, and we're making reference to the countries that have over 10,000 with a reference rate over 100,000 population. Now, these do not have a very high incidence compared to other countries, but due to the population volume in Mexico, the number of cases is obviously high. And we can see what the higher rates are. Brazil, for example, which has the most number of cases, Peru, Mexico, Haiti, Colombia, Argentina, Venezuela, and Bolivia show over 10,000 cases, but we know that Haiti, even though does not have a very high rate, the incidence is very high within their population. Doctor, there's no rush. Okay, in the same way, I would like to show you the chart with a lower tuberculosis incidence, and we see that not all of them, but a lot of these countries are identified as a Caribbean island. They're small countries, and the health services are very controllable, and they work a little bit better as far as identifying and treating cases because of the volume of population that they handle. The next slide, please. Okay, we also have data for the year 2020 as far as new cases and relapse, which begin with initial diagnosis through a quick test, which is one of the World Health Organization's suggestions. Now, the number of cases that are confirmed through quick test has been stable. The next one, please. These are data as far as estimates and notified cases, as well as the ones that are under treatment for the cases of RR and MDR. We don't have estimated data as far as RR and MD, TVRR and MDR, but we can see how the percentage in brown is the number of estimated cases. In red, we have the number of confirmed and notified cases. So as you can see, there's a big gap that we have not been able to close, and I don't think that we're going to be able to close it even with the data from 2020. And where we can see an increase on is on the percentage of confirmed cases, as well as the ones that are under treatment. In other words, the number of cases under treatment has increased. So at least we have been able to have our patients under treatment. So the coverage of treatment is the percentage that is in bold black. Okay, the next one is the percentage of new cases as well as treated previously, pulmonary confirmed cases. The sensibility tests that have been done to new cases and previously treated cases, and how the trend has been. And it is positive that despite the pandemic during 2020, a lot of people have been able to have these tests done. Now, the countries that notified TB, that notify pre-XDR TB cases and TB-XDR cases in Las Américas are mainly Peru and Brazil, but it is also interesting to see what the notification is as far as this type of cases in the different countries. Now, the next slide, please. The number of people with tuberculosis between the different groups. This information is not available for the 2020 report, but it is available for the 2019 report. Now, the highest rate is among people who smoke, people that consume alcohol, HIV, people living with HIV, people that have addiction problems. We also have some data as far as the load on indigenous populations, but especially we have to pay close attention to people that suffer from drug abuse. In Mexico, for example, at the border region is an important issue, and it is important to work together and hand in hand with the different institutions that give services to people who abuse drugs. Now, the trend as far as mortality rates due to TB in the Americas, I would say that we've been pretty flat in the last 10 years until we hit 2020, where, you know, the pandemic can be seen, especially for people that live with HIV. And this is what is reflected, is basically reflected on this chart. Next slide, please. I also wanted to present to you the TB cases, the patient TB cases that are also aware of their HIV status, and the percentage of these people that know that live with HIV and are also diagnosed with tuberculosis. And as we can see, there has been an increase in the screening coverage within the people that live with HIV and the testing with TB. In the last couple of years, we've seen a decrease, and we see that the percentage, the positivity rate has been stable. And you have probably seen this data because these are data from the years 2017 to 2019. And it shows how many, what's the estimate of TB HIV cases as well as the notified cases. As far as the results for tuberculosis treatment, I don't know if it's me, but the coverage for preventive tuberculosis for people who live with HIV in the last years in the region, both have increased the number of people that are registered with HIV as well as the number of people with preventive therapy for tuberculosis. There has been an increase, even though we're still far from our goal. Next, please. Okay, really quickly, the contact information or the notified cases, we also studied the notified TB cases of people who were also screened for diabetes, and we see how some countries have advanced a lot. They're pretty small countries such as Bahamas, but for example, Peru has a very high notified TB cases that are also screened for diabetes, and for Mexico, we're also over the average in the Americas. Next slide, please. This graph shows a list at a regional level for the year 2019 about the countries that represent, for which this is a proportion of TB cases and notified for people that are prevented from their freedom. And this is an interesting piece of information that I wanted to show you. Next slide, please. The percentage of cases in indigenous populations, obviously in countries that have a greater indigenous population, well, they obviously have a more important load, and this is something that you have to take into consideration as a denominator. Guatemala, Belize, and Canada that has more indigenous people, well, they have an important load. Mexico is one of them, but not all of the countries report their indigenous population cases. And we only have the information from the countries who report this information on indigenous population. Next slide, please. The percentage, well, here we show the percentage of successes, failures, deaths, and follow-up within different cohorts per se. The first one are new and relapses. Then we have the retreatments and TB and HIV, population under 15 years of age. And then we see that the most success has been seen in the age group under 15. We've also seen some advancements in the cases of retreatment as well as on the MDR, together with the impact that we have had as far as the control of this disease. Next slide, please. Well, so how are we doing at a regional level for the three main indicators of our tuberculosis strategy? What we can see what we have as a base for 2015, for 2020, as well as the milestones that we have from 2020 to 2035. But if we check or we look at the 2020 data, we can see the 35% reduction on deaths. This means that we would need to have about 16,000 deaths, but we're at 27,000 deaths right now. So we're far from this milestone. We're also far from the milestone for the incidence rate. We should be on 22 for every 6,000, and we're about 28.5, and we don't have any data as far as households that have to deal with really high costs for treatment. We have not done these kinds of surveys to determine the data. Next, please. These next indicators show other important indicators, the strategy to end tuberculosis and how it has been advancing in the American region. And I am sharing data from 2019. And obviously in the treatment coverage in the Americas region, we have gone back. We've gone from 82% to 62% in 2020. We have also been set back importantly in the treatment that we give to the age group under 5 years of age. And also important, the mortality rate has increased from 2019 to 2020. There are some indicators that have improved. For example, the coverage on individuals with tuberculosis, with patients that live with HIV, but we're still very far from the goals that we have set for ourselves. And so I was saying in 2019, we were doing okay, but in 2020 we were hit by COVID, and all of the public health programs, especially the tuberculosis programs, were badly affected. As we have been seeing, one of the most important impacts was the number of case notification, but I encourage you to read this report so that we can start moving towards accomplishing our goals. And through this report, we can see the impact that COVID-19 pandemic has had on us. And this is super important when we talk about tuberculosis, because we know that poverty is one of the social determinants which plays a special role in this disease. So this setback that we have had is something that we have to overcome, and we're going to see the impact in the transmission of this disease, being poverty an important risk factor. Next one, please. We have seen this important effect on the number of case notification. I'm not going to get into more detail, but this have been the greatest impact that we have had, or that we've seen at this time. This is something that's very tangible. There are many, we'll be seeing the impact at a long in a long term lately. But next one, please. We have, as far as notification, I simply wanted to show you a slide on what the reduction has been by country. These are also data that are available. These are the World Report for 2021. And we can see how most countries in our region, especially the ones with higher load, they have had an important reduction in the number of notification now. As far as the countries with higher load, we will have to see what the indicators will be in the long run. The number of deaths, which we have seen, is a direct consequence that we have seen as a reflection of the impact that the lack of health services during the pandemic for people who were already diagnosed with this disease. Next slide, please. Very quickly, I would like to show you this graph to see how how we were doing the 3 first months of the year during 2020, and how in some countries the notification went down. We can see that in Brazil, for example, in April had an important descent on notification, which started going up again. Chile also had an important impact on notification. The Dominican Republic the case notification was impacted importantly, as well as in Mexico, and in most of the countries in the region, you can see an important impact on notifications, especially in the month of April, where it was declared a world, where the pandemic was declared a world emergency. I don't know how I'm doing on time. We have time, doctor, do not worry. Okay, well, what are the key messages that I would like for you to leave with after my presentation? As far as regional and global level, the essential health services have been impacted due to COVID-19. And of course, this has also affected all of the tuberculosis programs. And according to all of the data that we have gathered for the 2020 report. So we have seen the impact already. Now, the most important impact that we can see is on the diagnosed patients. But we also know that there are other impacts that we're going to be seeing in a long term, and it cannot be estimated yet. We don't know what mortality rates are going to be set back to. And at a global level, this is determined by the countries that have higher loads, such as India and all of the Asian Southeast. So basically, we, as far as the reported incidents, we were kind of stuck, and it was an increase since 2015. And then we have to analyze how this pandemic affects us, particularly in the Americas region, because we have seen a decrease in treatment coverage. Since 2019, we were at 82% and we're at 69% now. We were at 69% in the year 2020. Cuts on budget, you know as well as I, what the pandemic has caused and how it has impacted all of the prevented programs and all the impact that it has had in public programs in general, because we have to assign all of the resources available to treat the COVID-19 pandemic. And this has affected all of the countries in the Americas. Now, if we were kind of stuck as far as advancing towards our goals, now we're obviously even harder from getting to those goals, because the impact of some of these indicators are not going to be able to be measured till a little later. And this is all I had to show you today, or to share with you today. The next one, please. This is something that the Global Tuberculosis Report for 2021 is something very easy to read and explore. You can do this digitally, and you can easily have access to the information to the different regions. There is some information that might not be available as part of this report, but in the mobile app. But if you want to get into this, and you can get in contact with us, and we can share the information that you might need. Now, this is the global report, which you probably have consulted, I hope, and I hope that you also have been able to see how the information is displayed for the 2020 report, which is very similar format that had been used for previous reports. And this is all on my part. Thank you so much. I hope I did not give you, I hope you were not overwhelmed with all of the information that I have given you. And I thank you again for facilitating the slides from the TV Washington regional team. I think that at the end, I went pretty fast. Thank you, doctor. Thank you so much for your presentation. And now we have a lot of questions that I hope you can kindly answer. I'm going to begin with the first. I hope I am able to answer them because remember that at regional level, all of the reports were from my partners in Washington, but of course, I'm going to try to do my best to answer their questions. Otherwise, I'm going to relate any more specific question to my partners in Washington. Okay, I'm going to begin with the first one. With the use of technologies of massive sequencing, the pharmacodependency rate has been increased. Is this correct? Well, I understand that there's a particular graph that indicates an element for the 2020 cases. So it is something that they have been working on. The change of technology has not been easy for the different countries as well as the resource implication, but we have seen an increase in some countries more than others, but at a regional level, we have seen an increase. To give you exact data, I would have to review it again. And if you want more specific information, I can review it with our regional team if you want information for a particular country. Very well, then the next question is, are there enough cases of tuberculosis in immigrant population? Is there an initiative in order to study these populations systematically? Well, we have in one of the graphics that I presented, the load of diagnosed cases estimated among the immigrant population, and all of the countries report to the global system the number of cases that they identify within the immigrant population. But we have to keep in mind that, for example, in the case of Mexico, there's a big difficulty to follow up on immigrant population because a lot of them are just in transit or commuting from one country to another, and they do not go to the health services available even if they present some symptoms. So the countries that can detect immigrant cases within immigrant population, this information is reported, but it is not important to follow up these cases. Even though they might get started on treatment, a lot of these individuals do not continue with the treatment. So there are different policies in different countries in our region. But if we think about Mexico, the program does its best to try to give treatment to all of the people that result positively diagnosed, but following up under treatment is difficult and it's a different story. So are you doing the mandatory report on COVID-19 and TB cases? Well, the people that have been diagnosed with both infections, we lack the report for that. We have not gathered those data. I know that some countries, or at least Mexico, have been registering people that have been infected by COVID-19 as well as tuberculosis and their results during treatment, but unfortunately, I don't have the information at hand. I don't know if Dr. Luna is connected to the national program and could have specific data for Mexico, but we do not have specific information at this point. I don't doubt that the report will be released, but we don't have it as of yet. The next question is, what is the reason for El Salvador to report a new number of cases for those people that are lack freedom? And this must have to do due to the treatment that they have access for, they might not have a very specific health treatment for this population. But what is clear is that the epidemic in El Salvador is prevalent, especially in that population. I know that the Salvador program, that for the Salvador program, some Mexican experts have participated, and I understand the dynamic of this has been applied. Unfortunately, I don't have a specific information. I know Dr. Laniado has participated in the review on some data from El Salvador, but I don't think he's in this call, but I don't have specific information. The cases, the report of cases among indigenous population is the report on indigenous population cases mandatory. Well, all of the countries that detect tuberculosis cases among indigenous population have to report them. What happens? There are population that live which lack access to health services. So most likely the load in some countries might be a lot higher than what they report. But the report is mandatory. This is something that each country has to report it at their epidemiological surveillance system. Sometimes it has to do with access, because a lot of these populations lack health services because of this. Thank you so much. The last question is, why, what is your opinion as far as what the reason is to stop following tuberculosis treatment? Well, we're very good at diagnosing and then giving treatment to our patient, and we feel that somehow we are doing our work by just doing that. But some of our health systems in general, they're not strengthened enough to have a successful follow-up program to analyze the different causes for people to stop treatment. There are different studies that show some data, but systematically, the tuberculosis control programs do not have specific information with most of their patients, which are treated by the different levels of public health. So I think that one of the main problems is the mechanisms that we have in place to follow up on their treatment. And generally, lack of resources has a lot to do with this. So the less resources the programs have, the more we're going to be seeing this situation prevail. Okay, we have one more question. Now, in this post-COVID time, what practices were done for diagnosis and follow-up of tuberculosis cases which could continue being used currently? I did not understand the question. Now, after COVID, what practices were done in order to diagnose and follow up tuberculosis cases which could continue to be used? Well, some countries, they started using a differential diagnosis. Some of the symptoms, what they did were take advantage that they were receiving patients with certain symptoms because of suspected COVID cases, and they took advantage of this in order to also perform tuberculosis tests. And that's how they were able to do more screenings on this. So I think that this will be a very good practice for at least the time that the pandemic still lasts, because this could help us increase the number of testing, following some of the criteria that is used for COVID testing. So we would have to think about a system in order to increase diagnose for asymptomatic tuberculosis patients. Thank you so much, Doctor, for your participation. There are no more questions. Excellent presentation, a lot of information. Thank you for sharing your contact info. Thank you so much. I hope I was able to answer your questions. If you have any other questions that you might want to ask about more specific information, I can share it with my team in order to answer them. And now to conclude this second session of the tuberculosis virtual forum, we remind you that for next week on Thursday, we're going to have a conference on the latent tuberculosis diagnosis advances given by Dr. Patricio Escalante, as well as a conference on latent tuberculosis, the success of surviving hitting, given by Dr. María de Jesús Garcia. We thank you so much for being here. We remind you to register through the QR code, which is available through the different channels that we have. And we also remind you that you have to be in 6 sessions in order to get a certificate for this forum or a diploma for this forum. Thank you.
de lengua de señas mexicana.
We also thank our sign interpreters for their participation, as well as Luisa's interpretation from English to Spanish, Spanish-English. Thank you so much for your support. And we also would like to thank the Autonomous University of Baja California, as well as the U.S.-Mexico Border Health Commission. Thank you so much, everyone.